after 1 month. My name is Dr. Natalie. I'll be your moderator today. So just a little side note on housekeeping. Kindly off all your videos and mute all your speakers because we do not want to interfere with our 3 wonderful presentations after this. And there will be a QR code at the end of the session where you will get your cert. During the presentation, if you have any questions, please don't be shy. There's a chat box under Zoom. So click on the chat box, type in your questions. We will answer all the questions in the chat box. And after all 3 presenters have presented themselves, then we will have a Q&A question as well at the end of it. So we will discuss some very burning questions at that time, but don't worry, all the questions will be answered in the chat box. For those of you who are on live Facebook, do post the questions there as well. We will have another host that will be collecting our questions there. So today we will talk about pelvic injuries, which is a very common injury in polytrauma, or it can present itself as an isolated injury as well. But do they get the attention that they are due? They are not as popular as our thoracic injuries, airway injuries, and definitely far from neuro injuries. So does this modest pelvic injury require our attention? Let's bring the spotlight today to the fundamentals of unstable pelvic injury. So the topic today will be divided into 3 parts, which is part 1, the initial assessment and resuscitation, followed by part 2, stabilizing the unstable, and the last part, angioembolization of the pelvic injuries. So I would like to introduce our first presenter today, which is Dr. Muhazan Mazlan, who is a wonderful friend, a great teacher, and a great team player. He is an emergency fellow, emergency physician, and he actively contributes in Mascot Society as well as Wilderness and Medicine Society of Malaysia. Dr. Muhazan was a houseman in Hospital Sultanah Aminah, medical officer in Hospital Klang, and he did his master's in University Malaya. And he was head of department in Hospital Lahad Datu as well. So today he will present the part 1 of the topic, which is initial assessment and resuscitation of pelvic injury. Pass the time to you, Azan.
Thank you, Natalie, for the kind introduction. Hello, guys. My name is Muhazan Mazlan. You can call me Azan. So, sorry. Let me just see if I can adjust my slides. All right. So, thank you, everyone, for joining us today. So, this month's topic is unstable pelvic injuries, the fundamentals. And I'll be presenting the first part, which is the initial assessment and resuscitation. And lucky today, we have 2 other presenters that will continue the discussion from different aspects. All right, Bismillahirrahmanirrahim, let's start. All right, I have no conflict of interest, and this is the outline of my presentation. All right, introduction. Pelvic injury comprises of 12% of all trauma. Sorry, I think. All right. I would like to ask the participant to mute their. All right, thank you. All right, so let me start back. Introduction. Pelvic injuries comprises of 12% of all traumatic injuries, and most of it is due to road traffic accidents. And as you might guess, usually it's involved male. In a bimodal distribution, the younger age group, the young and restless, and the elderly. So why is it such? Is because even the mechanism of injury is divided into 2, the higher impact and the lower velocity. All right. So the lower velocity, because when you think about pelvic injuries, you always think, oh, high impact mechanism, and you only think that young people who are driving, who are riding motorbikes are involved. But to be honest, the other distribution, the elderly and those with comorbids, also can be involved in pelvic injuries, especially when elderly people whose bones are osteoporotic, those undergoing chemotherapy, and those with degenerative bone disorders. So the elder and the comorbids population could also be involved in pelvic injuries. All right, so high energy mechanism, most of it is motor vehicle accident, comprises of 60%, and also pedestrian impact also fall from height. Now, the interesting thing is, pelvic injuries mortality rate is very high. If you see, generally, the mortality rate for pelvic injuries are 30%. If the patient has a unstable, it goes up to 42%. And if the patient has an open book fracture, it's 60% mortality rate. So meaning out of 10 patients that we get with open book, we only could save only 40%. All right, so this is the general anatomy. I'm not going to touch so much on this, but apart from the bones that you need to remember, because it's not a pelvic fracture, it is a pelvic injury. So apart from the bony fractures, you always to remember that inside the pelvic cavity, it holds a lot of your organs, your spine, your urogenital, your bowel, right? So the injury will come with a package, right? Not just the bony fracture, but also other organs may be involved. All right, so we're going to talk about basic classification. There's two main classification that we use. The first one is Thal's classification. And if you look at Thal's classification, the classification is based on the integrity of the posterior sacroiliac complex, and also depending on the rotational and also the vertical plane, right? So in tile A, as you can see, the pelvic ring is preserved, it's stable, and it's vertically stable also. So all those fractures that does not affect the ring or the vertical plane is classified in tile A. Whereas in tile B, you have a rotationally unstable ring, okay, but your vertically is stable. All right. So rotationally unstable and vertically stable. Whereas in tile C, you have both rotationally and vertically unstable. Right. As you can see here, it's rotationally unstable because there is injury over the ring, but vertically it is still okay. But when it involves both, for example, this, it disrupts the ring and also it affects your vertical plane, then it is tile C. Right, we will talk a bit later on what are the significance. The second classification is the Young-Burgess classification. It's primarily based on mechanism of injury and the direction that the force is applied. So if you look at this picture, the lateral compression, okay, when you have a side impact, and this one is anterior posterior, and this is vertical shear, and there's something called combination also. Okay, we dive a bit detail in the mechanism. So let's say someone has a motor vehicle accident and the force is delivered in the anterior posterior plane. So what it does is it will open the pelvis and it will splay your pubic symphysis, and at the same time it will rupture your sacral ligaments and it will cause a sacroiliac joint disruption, and in turn might tear the venous or artery. All right. And for your information, anterior posterior compression is also known as an open book fracture. All right. What about lateral compression? You say. All right. So you will have a pubic rami fracture, and if it's further compressed, then it will even crush your sacroiliac joint, disrupt the ligaments. You see, when you disrupt the ligaments, the ring is no longer stable. All right. And this is the importance of the rupture that we want to look out for. Apart from that, it will rotate contralaterally your hymen pelvis, will cause tension over the vascular structure, and when the pubis is driven into further, what will happen is you will injure your organs like your bladder and your urethra. All right, and what about vertical shear? Usually happens when a patient is fall from height or jump from height. It will displace also the joint, it will displace the sacroiliac joint, disrupt the vasculature, and like I said just now, when you disrupt the ligaments, there will be major pelvic instability. All right, so now we go into the next part, which is the major hemorrhage. Now, why is the bleeding so profuse in a patient with pelvic trauma? All right, so remember, apart from the fracture over the bones, you can also injure the venous plexus and also injure the artery. And on top of that, you could also injure your extra pelvic sources, your organs, your rectum, etc., etc. So you just don't bleed from the pelvis alone, not just from the pelvic bone alone, but so many other injuries. And mostly, however, is venous, all right, 90%, but 10% is arterial. And the worry about an arterial bleed is that most death and most patients in shock are due to arterial bleeding. Now, why is arterial bleeding so important for us to know? Is because arterial bleeding is usually the cause of hemodynamic instability. So 70% of patients who are unstable are from arterial bleeding, number one. Number two, you can detect that when the patient is still bleeding despite being stabilized. So meaning, if the patient has already been put on binder and the patient is still bleeding and you still cannot stabilize this patient. So you must suspect that at this point, there is an arterial bleed. All right. And just now we were talking about the SI joint disruption. I mentioned it a few times. Now, one might wonder, why are we thinking so focused on the SI joint disruption? This is the reason why. If you look at the SI joint, all right, just anterior to the SI joint is where all the major arteries pass through. So when you have a pelvic fracture that has an SI joint disruption, there is a high possibility that you will injure all the major arteries. And this is the thing that we want to elicit. All right, so the arteries involved, mostly anteriorly is the internal pudendal, whereas posterior is the supragluteal and the lateral sacral arteries. Now the patient is bleeding, but then you're thinking every bleed could have a tamponade. You're right, but in this situation, in a pelvic fracture, one, the the patient can bleed into a free space. Number one. Number two, the patient could also bleed into the retroperitoneal space. And the retroperitoneal space can accommodate up to 5 liters of blood. And when you have the parapelvic fascia disrupted, or the pelvic floor disrupted, meaning the bleed is free flow, right? You can't get a good tamponade effect. And that is why pelvic injury are associated with profuse bleeding. The West guidelines suggest that the hemodynamic instability be defined as hypotension, BP less than 90 millimeter mercury, significant blood transfusion, 4 to 5 packed red blood cells, and also significant base deficit. All right, so next we're talking about major injuries. In unstable pelvic fractures, 32% of this fracture involves intra-abdominal bleeding, and almost half of it is either the spleen or liver. And imagine a patient who already has an unstable pelvic fracture coupled with a splenic injury, right? So now it's double trouble, okay? Of course, don't forget the patient can also injure the urologic trauma. A renal pedicle can bleed profusely. And of course, the one thing to remember is that although the patient has no hematuria, the patient can still have urologic injuries. All right, so you know all this. Now we proceed with your primary survey, your initial assessment. All right, so I'm not going to focus from A, B, C, D to E. But now we're going to highlight on the circulation and hemorrhage control. When the primary survey is done, of course, you start from beginning. But remember, always examine the patient, palpate the patient. And when you examine the patient, always remember, palpate the abdomen, but also remember to look at the pelvis. Look out for ecchymosis, deformity, asymmetries. Don't forget also to look at the groin area. Uh, One thing that I see is some people do not expose patient properly because they want to respect the patient's privacy. However, by doing so, by not properly exposing, you could actually miss a pelvic injury by not exposing, by not detecting there is blood at the meatus or a scrotal hematoma or PV bleeding. And during your initial assessment, always remember to also check the lower limb discrepancy and also neurology of the patient. All right, so now we go to on the first part, the pelvic palpation. Please remember, we no longer advocate for a pelvic spring. Imagine the patient has already a pelvic fracture, and what you do is you spring the patient's pelvis together, and logically what you see now is you're going to further push the injured part, the fractured part, inwards. And this will worsen the injury that the patient already had. So you should just only do a single hand palpation, and you should do it gently. All right, you should palpate the bony prominence and do compression gently, anterior, posteriorly, and also the laterally. And if the patient already have signs of pelvic injury, all right, or the patient is unstable, or the patient has a very high impact mechanism of injury, usually we will try to avoid from doing this, right? But if they are stable, the mechanism of injury is low, there's no signs to tell that there's a pelvic injury, then you should proceed with this pelvic palpation. All right, this is what I told just now, palpate around the body structures, lateral to medial and also anterior to posterior. All right, next we talk about log roll. Okay, as you know, log roll is an important component. You can actually log roll patient whether it be in circulation or be it in disability or even in exposure, right? However, you have to make sure that you clear the patient first, the pelvic first, before you do the log roll. All right. Why? Because by log rolling a patient with a pelvic fracture, you risk the hemodynamic instability. All right, because you're moving, because you already bind the patient, but you're also moving it. All right, and if you don't bind the patient and you move, then this movement will actually destabilize the pelvis. And the other issue is you will actually prevent the patient from clotting properly. And remember, the first clot that the patient has is the strongest because the first clot already consume your factors and coagulating factors and platelets. So the subsequent one will be formed, but it won't be as strong. All right. All right. So next, but in the situations where the airway is compromised, let's say a patient is restless, vomiting profusely, or you see there's accentuating bleeding from the back, then you have to do log roll. There's no choice, but please bind the patient first. All right. All right. But let's say you have a pelvic fracture. How do you examine? All right. So you can't do a log roll, but you can always check your floor, your bed sheet, and with a gloved hand, you actually could do a hand swipe to detect any major injuries or bleeding. So when this happens, you can also still detect whether there's any bleeding to the patient. All right. When you've already done your examination in circulation and you've already decided clinically or radiologically that the patient's there is no pelvic fracture, then by all means, please proceed with your log roll. All right, so we go to the second part of this talk where I'm just going to go about this 7 stepwise approach in approaching a pelvic trauma. So for your information, every 3 minutes of instability without proper hemorrhage control, it increases 1% of mortality rate. So the first step is resuscitate. Do your primary survey and your adjuncts. Please hold on to hemostatic resuscitation principles. Immediately clear the pelvis clinically and radiologically. Stabilize the patient's pelvic as soon as possible. And if you feel that the patient has, you need to intubate the patient, we suggest that you actually bind the patient first before intubating, because when you give your muscle relaxant, you actually allow the pelvic volume to expand. Of course, your blood transfusion, your analgesia, and transient aspect should not forget. Now, while resuscitation, there's two things that you should be considerate about. Of course, you always look at the blood pressure and heart rate to assess stability. However, you can also use your base deficit, your blood gas, your lactate, your metabolic acidosis as a trend. Okay, observe it as trend, but because by this trend, you can actually see the extent of the hemorrhagic shock, and you're able to manage you want to manage to monitor the patient's response to resuscitation. Next step is pelvic binder. Pelvic binder, it is effective to reduce the unstable pelvic, and is actually as good as a definitive stabilization. Okay, for the time being, for the temporary, and it works in emergency setting. It works as good as your external fixation. Okay, all right. Why is it good? It is safe. It's time effective. Low skills. You don't need a orthopedic surgeon to come down and do the X-fix. It's a good strategy, grade 1A, to actually stop the bleeding. And the rationale is actually to reoppose the bony surfaces in a reasonable alignment so that you can control the bleeding. So, when you bind the pelvis, the few things that you can achieve: reduce injury, reduce bleeding, achieve tamponade effect, decrease the volume, and also decrease the pain. Now, then you ask me, is there any evidence on what you say? All right. We have looked through a lot of guidelines and literature. There is one systemic review. Although they found that there's not many researches done in pelvic injury, but they saw 16 studies. There was a bit concern regarding the methodology, and also it's more of observational and lab-based study. But one thing that they established is that from all this review is that it assists with homeostasis, and it actually improves stability and reduces the amount of blood being transfused. Then the next question: do you use pelvic binder in a prostatic setting? The answer is yes. Please use it immediately, even in prostatic setting. And I think that all our MAs and medical officers are well aware and well versed in placing a pelvic binder. All right, few things to remember. Pelvic binders are superior to a wrapping sheet. Okay, sometimes we use the white cloth to bind, but if you have pelvic binders, use your pelvic binder. Don't use it too high. Place it at the greater trochanter, and if possible, to draw the legs together. All right, and what you want to do is you want to remove it as soon as physiologically justifiable, either when the patient goes to OT or the patient is cleared from the injury. But if you have cleared the patient for injury by CT, you still have to monitor. You remove the pelvic binder, you still have to monitor hemodynamics, because sometimes it can hide the injuries, right? And perform a chest X-ray once the binder is off. All right, step 3 is your adjunct. All right, I think this one is quite clear cut. Everyone is well versed, not only in emergency department, but it's done by other departments also. The fast scan is important, and if it's positive, it's a sign that the patient warrants a laparotomy if patient is unstable. All right. Next is the CT scan. So your CT scan is an excellent tool to exclude pelvic hemorrhage. All right, and but if the patient and if the patient has a negative fast and is stable after resuscitation, and this is the kind of patient that you really need to push for CT. Okay. However, if the patient is unstable, then you need to consider. Right. Usually, we try to avoid sending an unstable patients to the CT. Patient needs to be resuscitated and sent to OT immediately. But the stability is, of course, is dependent on the trauma team itself, the physician and the surgeon in attendance. All right, so now you already resuscitated the patient, you've already given blood, you've already used your adjuncts, you've already binded the patient, and the patient is still unstable. Now, this is when you need to step back, stop, formulate, and make a decision. And decision is made by the whole team, meaning the whole team have to make a decision on what is the best way to stabilize this patient. So discuss with your team members and look at what options you have. Right. So things that we can do to further stabilize this patient is there's three steps. The first two is the external fixation and the pre-peritoneal packing. So these two steps will further be discussed by my colleague, Mr. Faisal Manan, on regarding the orthopedic aspect of stabilization. So this part, remember that this external fixation will help in venous bleeding. All right, if you already fixated the patient and the patient is unstable, then that is the thing that we need to go for. All right, what it does is it gives a rigid temporary pelvic ring stability and is also used as an adjunct to stop the bleeding. All right, with together. So meaning usually they will use together. This one we will discuss further details later. Pre-peritoneal packing and also external fixation to stop the bleeding for the pelvic patient. So then you're asking me, what is pre-peritoneal packing? My colleague will explain in details, but roughly it is a surgically placed pads to tamponade the space. All right, so you can see here, and it's done together with your external fixation. So what are your indications? Okay, so if you have angiography in your hospitals, then you can proceed with angiography. But if you don't, this is the only option you have. Uh, if the patient cannot go to angiography because patient needs a laparotomy, that is your option. Patient who is unstable despite being stabilized or resuscitated in refractory hemorrhagic shock, or in situations where the patient has got angiography, has got external fixation, and is still bleeding, right? And of course, expanding hematoma. So the last step, which later will be discussed in further detail by my other colleague, Dr. Arvin, is angiography and embolization. All right. So what is angiography and embolization? We will talk in details later, but you need to know that this is an option in those places with interventional radiology services. It has 90% successful rate. It's both diagnostic and therapeutic. And the indication is those patients who are unstable despite packing, those who pelvic blood loss has been ruled out and is still unstable, those with active arterial bleed, those with retroperitoneal bleed, those with ICE, which is IV contrast extravasation, those with expanding hematoma. So these are the patients that need to be pushed for angiography. All right, so I've come to my last slide. As a summary, right, pelvic injury is important for you to know, for you to be familiar with. It is something that we need to focus on. So the few things that we need to put in mind is number one is a common injury, like we said, up to 12%, complex, multiple organs and vessels involved, high mortality, like we said, 60% in an open bone fracture. Avoid pelvic spring. Okay, you just do your pelvic palpation. Avoid log roll if you've established that is a pelvic fracture. Clear the pelvic immediately, radiologically or clinically. Close the pelvis, bind as soon as possible. Look for other injuries. Use your fast scan, use your CT scan, and manage the patient if the patient is unstable despite resuscitation according to the availability, whether it be damage control surgery, damage control orthopedics, interventional radiology. And lastly is managing a pelvic injury is a teamwork. All right, it is important for us to work together. Just like the CME, where we have an emergency physician, orthopedic surgeon, and interventional radiologist. This is how we should manage and trauma surgeons. This is how we should manage pelvic injury. If you can see, this is a real case on this picture. It's a trauma team activation back when I was a medical officer. And the concept is work together so that we get the best prognosis. All right, that's all from me. Thank you very much. Back to you, Natalie.
Wow. Thank you, Dr. Azan. Thank you for the many steps and a very simplified steps for us to follow. And it's true. So I think that pelvic injuries we really do need multidisciplinary approach, and thus that's why today we will have spines, we will have orthopedic surgeons with us, and as well as radiologists with us. So without wasting any time, let me introduce our second speaker, who is Dr. Faisal Manan, a committed and compassionate orthopedic surgeon, and a person who works well and leads well. He often takes up new challenges just to keep himself up. So Dr. Faisal did his undergraduate in Dublin, Ireland, and did his master's in University Malaya. And currently he is a spine fellow and currently working in HKL. Dr. Faisal Manan previously worked in Hospital Klang, Queen Elizabeth, and Hospital Sungai Buloh. So let's go on to our part 2 of stabilizing the unstable pelvic fracture. Time to you, Dr. Faisal.
Okay, thank you, Dr. Natalie, for the kind introduction. All right, I'm going to share the slides here. Okay, hi everybody. Thank you for being with us for today for the CME. Thank you, Dr. Shah, for inviting me, and Dr. Mohazan as well, and Dr. Sabaria. So without further ado, I will start the presentation. Okay, stabilizing the unstable. So I would like to start the presentation with a two case discussion. The first is a 25-year-old Grab driver. He had an MVA early this week, and then when he came, he was sitting by in the green zone for I do not know how long, and suddenly he collapsed. Then when he collapsed, he was sent to the resus, and when resuscitation, they found out that he had a pelvic injury. Unfortunately, he did not make it. He passed away even with the 11 pine pack cell transfused, and then they went into OT to do a laparotomy because they can't control the source of bleeding, and then subsequently with all the resuscitation, and then also with all the things that can be done for him, unfortunately he passed away. It's a sad thing for a young patient. So this next scenario, this is a 43-year-old gentleman who had an industrial injury. If you can see over here, from the cursor of my mouse here, this is the left leg here. It's been avulsed. It's traumatic amputation at the level of this iliac region. The hips is all gone as well. And if you were to follow closely, this is a peritoneum here. Okay, and this is the gluteus maximus. This is the butt itself, and this is from the radiographic X-rays. This is a right iliac crest, sacrum, and the left side is over here. You can see it's all comminuted, shattered, and nothing holding back. So if you were to see between these two cases, the first one, 25 years old, a simple patient who in the green zone looks stable enough compared to this patient who been, because during the time of injury, it was during the peak of a COVID, so patient was transferred, patient was brought initially by the boss from the factory to different hospitals, such as in private, and then subsequently after the third hospital, sent to Hospital Kuala Lumpur. Surprisingly, this patient survived, and when he came over here, we would expect that there's a lot of bleeder coming up from the iliac vessels, but that did not happen. It's thrombosed by itself. It's very, very lucky in compared to the first patient. So there's one paper published by Department of Orthopedics in Trauma in Ganga Hospital in India. This is a very good paper. They discuss management of pelvic injuries in hemodynamically unstable polytrauma patients, challenges and current update. If you ever have a chance to read a paper, I think this will be a recommended paper to dive into. So a bit of epidemiology. Globally, trauma is the 6th leading cause of death, and pelvic fractures occur only in about 2 to 8% of all skeletal injuries. The mortality rates in isolated pelvic injuries are around 8% and can be as high as 50% when associated with polytrauma. When a patient has a pelvic fractures, more than 50% of patients has other concomitant injury. The most commonly associated injury include chest, head, liver and spleen, multiple long bone fractures, urogenital, and spine. There are many reasons why a patient could die from a pelvic fracture. Most common will be hemorrhagic shock secondary to the pelvic fracture itself, and others from the multiple organ failure. If a patient have intra-abdominal injury, patient have interthoracic injury, or bleeding from other long bones, patient could die from hemorrhagic shocks either because of the other injuries, which account about to 16%. If a patient do survive the initial trauma itself, about 16% of the cause of death is secondary to septic shock, and others causes such as DVT. So when you have a patient with pelvic injury, like what Dr. Muhazzan presented just now, it was a very good presentation. It's concise, straightforward, and easy to digest. So when you have a pelvic injuries, you might have a stable or just a Vauchian kind of fracture outside the main pelvic ring, or it could involve the complex unstable pelvic ring kind of injury. Therefore, it does cause dilemma in diagnostic and therapeutic challenges in managing unstable polytrauma patient. Like Dr. Muazzam said, hemodynamically instability is something need to be addressed very vigorously in a patient with pelvic fracture or any other fractures or any other trauma to begin with. So there's a concept called damage control resuscitation. It is a strategy approach to tackle a hemodynamically unstable patient using permissive hypotension, hemostatic resuscitation, and damage control orthopedics. Or if a patient have other injuries, then damage control surgery per se. So what it means is we have to try to maintain the blood pressure low within the acceptable value. If the blood pressure goes too high, it can dislodge a premature blood clots, further aggravating the hemodynamically instability. Hence, the words permissive hypotension has been utilized and used over the many years in targeted with a systolic blood pressure of 80 to 90 millimeter mercury, which to maintain an organ perfusion. Again, the tranexamic acid is an antifibrolytic agent, which if administered within the first 3 hours of polytrauma, it significantly reduces mortality rates and is considered as part of hemostatic resuscitation. Even when we do like complex surgery, not just pelvic fracture per se, let's say spine and others, if we do anticipate bleeding, tranexamic acid does help a lot in reducing the bleeding. So how do you approach a patient who come with a pelvic fracture or injuries and who are in hemodynamically unstable? Like Dr. Muazzan have explained before, there are 7 steps, if I'm not mistaken, that the one that he presented just now. So that's a very comprehensive steps that you can approach or address. So early identification of the bleeding source is of paramount importance in controlling the hemorrhage. There could be multiple bleeding sources, which include the bone surface itself, vascular structure, soft tissue damage, solid organ injuries, and often to be concealed in a remote site such as vagina and perineum. While a gentle palpation for bony tenderness may give useful information, application of pelvic distraction can cause dislodgement of the clots. It is well known that the first clot is the best clot, and therefore vigorous examination may cause aggravation of bleeding and is to be strictly avoided. This is with regards to pelvic spring, like Dr. Muazzam explained just now. So with all the fractures, why do we have to have a classification? Many reasons. One is so that easy for a doctor to talk to another doctor. Number 2 is to, in this case, for pelvic fracture classification, to determine the stability of the pelvic ring itself. And indirectly, it denotes the amount of force involved to cause the disruption. The most common pelvic injuries are lateral compression injury, LC, which are not associated with major pelvic bleeding as a majority. Okay, of the posterior stabilizing ligament remain intact, unlike APC or vertical shear, APC, anterior posterior compression. Comparing the two classifications in predicting hemodynamically instability, both fare equally. However, fractures considered as unstable by Young and Berger's classification is better in terms of predicting mortality. This is an example of a fracture. You can see this is iliac bone. This is a part of the iliac bone that's been fractured, fractured through the bone itself. This is a sacrum here. The pictures has been described by Dr. Muazzam just now. So I just gonna show you a very brief. So this is a sacroiliac joint here where it's actually open up. Then this is a picture where about there's a posterior element of the iliac bone, the sacral, and also the joint open up here. And this is the view from the top row, and this is from the front view. So the top row or inlet view, you can see it's open up on both sides. One side is open more. There's a fracture to the sacral bone, and you can see the pubic rami is actually pushed in as well. Whereabout in this they are open up at the pubic symphysis. Okay, this image can give you some rough idea what are we dealing with, because sometimes pelvic do require a 3D analytic mind to have the concept. But nowadays, the good thing is we have a 3D CT so that it can actually guide us to a certain extent the nature of the injury and the configuration of the fracture itself. So when you have a pelvic fracture, the next question is, why does maintaining a pelvic volume important? Can we just like leave it open that way? In a normal intact anatomically pelvic, it can hold up to 30% of total blood volume and can even accumulate more than 50% of blood volume, leading to rapid, non-compressible source of internal bleeding. There are a formula that they use to roughly give you some kind of gauge of the volume for a pelvic cavity itself. So it divided into the height, the length, and the width of the pelvic with the equation above here. Don't worry, this won't come up for the exam. So this is just like for some understanding for you guys. Okay. So the pitfall in imaging. Imagings are good, but sometimes there are certain degree of limitation that we have to deal with. While the gross unstable injuries can easily be recognized in a plain radiograph, the posterior ring injuries can be missed. Though plain radiograph of pelvic is an integral part of ATLS protocol, the poor sensitivity of 67% identifying pelvic injury in hemodynamically unstable patients favor the usage of pelvic CT in evaluating pelvic injuries. Over the last 2 decades, WBCT or whole body CT protocol has overtaken the selected computer tomography SCT approach of the ATLS as whole body fares superior in terms of time of imaging, diagnostic accuracy, and mortality rates as well. They did a study and they found out up to 52% of clinically significant injury can be missed if CT of the thorax was not performed, if you were to compare this to a plain chest radiograph. So the next concept when we want to deal with stabilizing the unstable, there's a concept of damage control surgery. What it means is there's a goal or the aim is to rapid control of the bleeding, decontamination, and early stabilization of the fractures. Anatomical reconstruction is reserved to a later date after physiological recovery to prevent the secondary heat phenomena. The primary source of bleeding from unstable pelvic injuries include fracture surface, arterial bleeds, and venous rupture. Interestingly, there's a figure say if the pelvic rings open up by 5 centimeters, the pelvic volume increased by 10 to 20% as well. So from the previous data or the that I showed just now, in a normal pelvic can actually accommodate to 30% of the blood volume. So if you increase by 5 cm of the ring open up, you can see how much more the blood volume can be pulled. And in certain cases, there's you don't have the tamponade effect and patient keep on bleeding and bleeding and bleeding, as you can see and you can expect, like in the first case just now, the 25-year-old Grab driver who passed away. So the next thing is application of external fixator is in compression approach the fractures end, reduce the pelvic size, and also provide a tamponade effect for controlling bleeding. Like Dr. Muazzan mentioned just now, the pelvic binder is a good tool to have to control, because if you want to do external fixator, it's good to have, but it does need certain degree of surgical experience to apply. I once, when I was in Kelang, it's quite interesting, a 6-year-old girl riding motorcycle with their grandfather, and then I can't remember, hit by a lorry, a van, or a train. I can't remember which of those. At that time, patient was in ED, BP not stable for 6 years old, so, and the operation theatre was full. Ideally, we would like to do this external fixator to hold it in using the II image intensifier, using X-ray, so that we know where we are. So that because there are a lot of major structure that you can actually damage when you were to insert pin blindly or blind technique, especially when you do it in the pediatric groups, when the bone are soft and it doesn't have the same context or the same give way when you insert something in a normal adult bone. So for this patient, because if you were to wait for far too long, even though with the pelvic binder and all, patient still not stable, if you were to go to OT, there's no OT to begin with. So what was done as on my last day when I was in Kelang as an MO, so I think it was really early in the morning, maybe like 5 or 6 o'clock in the morning. Oh, sorry, maybe in the evening, 5 or 6 p.m. So we had to apply external fixator blindly down in ED itself. And thankfully, with external fixator, patient BP are starting to stabilize and patient are well better after that. And thankfully, patient survive. That's very interesting. So application of the external fixator, the main concept, just like a pelvic binder, is to create a tamponade effect. As per Young and Burgers classification, APC 2, 3, lateral compression 2, 3 are amenable for satisfactory stabilizing using external fixator in 64 to 83% of injuries. Before this, when we don't have enough advanced trauma surgeon, we do use external fixator as a primary device to stabilize the pelvic. For example, let's say patient come in with a open book, then we put external fixator, then patient go back with, because usually they have to use external fixator for, you have to maintain to close back the ring for duration of time, sometimes 2 months, sometimes longer than that, because usually ligament takes 6 months and, ligaments takes about 6 weeks to heal, could be longer as well, especially big ligaments. So we have to use it for longer duration of time. But if you were to keep patient for that duration of time in our limited capacity bed of a hospital, then you can have a lot of backlog. So those days when we don't have much expertise of surgeon who can approach the pelvic safely, so we use the external fixator as definitive. But nowadays, thankfully, with the fellowship program and then a lot of advanced trauma surgeon has graduated and been providing the service all over Malaysia. So we have been converting external fixator as primary to a definitive management using a plating or a screw to hold the fracture fragment or to hold the diastasis of the pubic symphysis that open up like such an open book. So however, in vertical shear and combined injuries, apart from external fixator, ipsilateral skeletal traction is also needed in 27% of injury. So what it means here, I think one of the questions that was asked just now in the chat box was, if you have a vertical shear, what else can you do and how else can you approach this? Yes, in a vertical shear, you can stabilize it, but sometimes ipsilateral skeletal traction is also needed, meaning that you can put skeletal pin and you pull either you put a femur or tibia, usually the femur, if there's no fracture, you pull it down, because in vertical shear, one side of the pelvic will go high up and rise up. So we need to pull that back down and we have to stabilize it, okay? This is an example of an external fixator. You can see this is an iliac crest. This is a yellow color of a bone, so this is not normal. All right, so there's a pin over the iliac crest, or you can see this is a suprastabular pin insertion here. The same concept, you have a bar to hold it together just to keep the volume and the pelvic cavity to create the tamponade effect and to stabilize it further. Of these two, the suprastabular pin is more recommended. However, it's a bit technically challenging, but still can be done. It's doable. This is some of the example of how do you do external fixator. So you identify the landmark. This is for the iliac crest. So you identify the landmark, then you know that you want to insert into the iliac crest here. So this, you divide it into the outer table and inner table. If you can see from here, the AO, they use a K-wire and look like sharp K-wire, which we don't advise to use a sharp object. We don't want to cause further injury, and you do not know what else down there. Sometimes you have like a floating bowel. You could like perforated or damaged it. If you can avoid using this, by all means avoid it. Basically, we want to go to the bone. What I do is I feel for the bone using my hand itself, and sometimes I use the forceps, the blunt side of the forceps. I create a space so that I can feel where the iliacus muscle is and where the bone is at. So so that gives me a rough idea where it is, and I insert the pin. So this is an example of suprastabular pin here. Okay. So then they stabilize it further with a clamp. External compressing device, this is what Dr. Mohazan has explained just now for the pelvic binder. Other than that, we have this called a pelvic C-clamp, whereby let's say if the SI joints open up posteriorly, you know that by applying the external fixator, you can't still close the posterior complex or posterior structure of the ring can't be compressed. You can use this pelvic C-clamp. They have a very good video on the AO website. AO is one of the main website that we use for orthopedic for a rough idea and then a guide for the treatment as well. So it's worth looking at AO. So it shows you how to put. There are a few contraindication of when you don't use this, such as comminuted sacral fracture. All right. So the next thing is, once you know that you already stabilize the patient to a certain extent, you try to put a pelvic binder, and if you can put external fixator, by all means. In certain scenario, even with all these, it doesn't work. What else utensil or what other utility that you have in your armory? There are things called the pelvic packing and also pelvic angiography and embolization. Pelvic packing and pelvic packing has been described and has been shown by Dr. Mohazan just now, so I won't go in detail for that. What about pelvic angiography and embolization, Dr. Arvind will explain further. In patient with pelvic fracture and hemodynamically instability, there's no current evidence to support the superiority of either of them, as there has been no significant difference in mortality rates. Angiography is considered a complementary rather than a competitive tool. However, it is most effective if done early, which therefore necessitates the availability of in-house experienced intervention radiologists. Sungai Buloh is very lucky to have intervention radiologists such as Dr. Arvind to help out with embolization and a few procedures which is quite technically challenging. And for them to provide the service around the clock, they should. We are thankful for that because it does help a lot, and patient life can be saved as well. So this is an example of how you do a pelvic packing, or even if you were to put a plate for open book over the pubic symphysis here, and when you want to close it down. So the same approach. So you open midline, then you dissect to the fascia, then you go to the this since it goes down a bit more. Usually, if you want to do pelvic packing, go higher up a bit here, but this approach can be used to put a plate here. Then you will feel for the bladder, you retract to one side. This is a bladder, this is a sponge. Then you start packing it. For example, in this picture, peritoneal sac, then you put the gauze around it. Abdominal pack usually. And this is the clinical picture. The head is around this region. The leg is down here. This is the belly button. So this is the leg. So this is suprapubic region. They open up. They open up the rectus abdominis, open up the fascia, retract the bladder, and also put the packing. You see this? This is a big gauze here. They actually pack a few. They do tend to go back in after 24, usually 48 hours to remove the packing and to see. Okay. The next thing that is interesting, in Hong Kong, they developed this protocol, a 3-in-1 protocol. So what does it mean? It's early control of bleeding from pelvic fracture by external fixation, meaning they apply external fixation. Then after that, subsequently, they put retroperitoneal pelvic packing, and they augment it further with angiographic intervention from these 3 pillars of protocols. All these are performed in the operation theatre in the same session. In the recent multi-center analysis, this protocol was identified as the most single independent predictor factors for 30 days, 7 days, and 24 hours mortality rates. So in the center, when we have this, it's very good. Implementing of such protocol reduce unnecessary time spent on discussion, arranging for the 3 crucial procedure, and transfer of these highly unstable patients. In Sungai Buloh, you have a trauma OT down there, was established by Dr. Shah Jahan. It's a very good concept to have. With that, you can save a lot of patient life, and then you can save a lot of time, especially when patient need to push directly from the resuscitation bay and to the OT directly. And with this 3-in-1 protocol, if it can be utilized in the future, maybe something can be going to down that line. So the 3 different measures adopted in the sequential protocol are supplementary and complement each other, and to achieve hemostasis in unstable pelvic fracture. However, to accomplish this one-stop resuscitation, there is therapeutic action, a vast network force involved, and a multidisciplinary team approach needed, such as the NS, the orthopedic, the general surgeon, intervention radiologist, radiographer, operating room technician, and nursing staff. Okay, just now we covered already using the external fixator as like I said before, they use it as a permanent rather than a temporary device. What it means by definitive is after external fixator, we change it to using a plate or using a screw, and then we remove the external fixator. Why is this a good idea to have? Okay, one, when you have pin for too long, there's always bound to have surgical site infection, especially patient obese. When the patient obese, the pins, sometimes the skin rub against it. When I was in Kelang, we did so many external fixator of the pelvic. We do see the wound breakdown around it. Sometimes the wound was small to begin with, and then it become bigger and got infected as well. There are cases where patient went back and got infected as well. So the idea of using that as a temporary and subsequently you put in a plate or screw to stabilize it is a very good idea. So it's called a definitive fixation. Okay, so definitive fixation of unstable fracture should be timed appropriately, strictly adhering to the principle of DCS and DCR. Delayed in definitive fixation is safe and has a predictable outcome in most of these injuries. One might argue, since we already bringing patient to OT, we're going to do a like pelvic packing, why don't we just put a plate directly there? You can, but however, in a patient who are unstable, this procedure might take a while. Especially as a complex fracture. Sometimes the pelvic fracture can take hours and hours. You can start in the morning, you can finish at that time. So in an unstable patient, you like to do the bare minimum. You don't want to destabilize the blood clot that's been formed, and you like to come out early so that you don't want to further aggravate the coagulation that has been utilized by the body itself. So you like to keep it safe for the patient. Ideally, if you're given a chance, of course, so that if you can do one all-in-one setting, you put a plate there, it would be nice, but it's not feasible idea. Even though some center have tried doing it, maybe they do the bare minimum, such as putting a screw or just a plate over the pubic symphysis. So it goes to the next point. While external fixation of a pelvic fracture has become integral part of damage control measure, internal fixation remains controversial and have been attempted only by few authors as part of early total care, meaning they do it very early. On the other hand, there are emerging concepts applying percutaneous iliosacral screw. This is further when the posterior element of the ring open up. So they put the screw, iliosacral screw. And then anterior pubic plating, use the same corridor used for pelvic packing, the one that I mentioned just now. In patients undergoing laparotomy for addressing abdominal or perineal injury, the same incision can be utilized for simultaneous management of anterior pelvic ring injuries using plating or screws. So a national-wide analysis of pelvic injuries in the US also support the use of internal fixation. Definitive internal fixation was associated with decreased odds of mortality. So meaning that if you put plate, if you put screw, you can actually, to a certain extent in US, they found out the decreased odds of mortality. Okay, traditionally, when do you need to go in and do the definitive fixation? So before this, before the evidence out there, definitive fixation of pelvic fractures was suggested beyond 72 hours. However, there's increased evidence which shows the feasible of safely performing definitive surgery within this time frame, which is also associated with the low mortality of 2.3%. Okay, so this example where you put this called a SI screw from the sacrum iliac to stabilize the fracture here. All right, so this is another example here when you have the ring fracture, iliac ring, and you put a plate and also you stabilize with the screw. Okay, and this is a part of the acetabulum. You can see that if you were to follow the Shenton's line, then you have then you can see there's actually there's a fragment at the back there. So this is a plate augmented to the posterior aspect to help reduce it. Okay. All right. So we are coming to the end of the presentation. So this again, 25 years old, Grab driver. Could anything else be done differently to save him? Maybe, but you can see over here, there's a iliac wing fracture here. There's a big chunk of it, and then if you were to look closely, the SI joint is open up. So, and there's a comminuted fracture to a certain extent here as well. I think because there's a lot of venous plexus at the back here, there's a possibility that patient actually bled to death internally, like especially when the pelvic ring keep on opening up and nothing to stabilize it further. And for this patient here, he survived like we discussed, but unfortunately because he's from Bangladesh, financially is always an issue for them. We would like to put a flap, we like to cover, we like to stabilize further, but there are only certain limitations that we can do for them. If they are local, unfortunately to say that, because of the cost of billing, it's very expensive. For local, we do try to waive those expenses to a certain extent and help them as much as we can. All right. With that, thank you.
Okay, thank you very much, Dr. Faisal. It's a wonderful sharing of a 25-year-old Grab driver, and thank you for showing like all the stabilization devices and the packing that you have. And we will keep all the questions to the end. And don't worry, Dr. Faisal, we have a few questions for you in store already in the chat
Okay,
box.
thank you.
Okay, and we want to make a special thanks to Medica Shifa for sponsoring our CME, and every month that they have fully sponsoring us so that we can learn more to treat our patients better. So going on to part 3 of the pelvic injuries, we have Dr. Arvin Rajadurai, who is a motivated and skilled neurointerventional and peripheral interventional radiologist. So it's already a very rare gem to find an interventional radiologist. He is competent in both neuro and peripheral and vascular as well. So Dr. Arvin is also an alumni of University Malaya and undergrad and postgraduate in University Malaya, and he had done his fellowship in Hungary, currently serving as neurointerventional and clinical radiologist in Hospital Sungai Buloh. Dr. Arvin is trained in vascular interventions such as central vein catheter, SVC stenting, mesenteric, lower limb, upper limb embolization, and thrombolysis, as well as neuroendovascular procedures. So without wasting any more time, let's invite Dr. Arvin for the part 3 of angioembolization of pelvic fractures. Pass the time to you, Dr. Arvin.
Thank you very much, Natalie, for that kind introduction. I'm also very honored to be here, to be with the giants of emergency medicine and also in trauma. I'd also like to thank Muazzan for the invitation to be one of the speakers, as well as Shah, and congratulate Muazzan and Faisal for your 2 talks. And I will just be complementing the talk and explaining on angioembolization in pelvic trauma. So I hope everyone can see my screen. Natalie, everything's okay? Can you guys see my screen? Okay, I'm not too sure whether anyone can see my screen or not.
Yes, we can see your screen.
Okay, thank you very much. So, as you can see, I'm going to be talking about the role of embolization in pelvic trauma. We actually serve in Hospital Sungai Buloh, which is, I think, before being a COVID hospital, it was a level 1 trauma center. And I think we used to get a lot of severe trauma, especially because we are next to the highway and easily accessible. And I used to get a lot of referrals from the emergency team and the trauma team, and we do our fair bit of embolization. So just explaining my outline of my lecture. So I'll be talking a lot about angiographic appearance of what angiograms look like, and how to correlate it with the CT scan, and what's the right management when we have to address patients with pelvic trauma and pelvic bleeding. So just as part of an introduction, this is just from Department of Statistics in 2020. So you can see that road traffic accidents is number 4 on the list of the 5 principal causes of death. And, you know, it is quite a significant amount of deaths happen actually in the below 40 group, you know. This is a different type of B40. And let me tell you that just to paint a perspective, this can be any one of us. It can be you or me, you know. Sometimes trauma doesn't choose. It's not because you live a certain lifestyle you will not get trauma, you know. It's not very forgiving also. So in pelvic trauma, trauma has a high mortality rates, and it's usually approximately 50% particularly with presence of fractures and hemodynamic instability. So the most common source of bleed, as Mozan has explained, is also venous, but unstable pelvic fractures, almost 2/3 of them have arterial bleeds. And in 70% of cases that do not respond to resuscitation in pelvic fractures, most often have arterial bleeds. So usually when you see active contrast agent extravasation demonstrated on contrast enhanced CT, so there's a high likelihood that there's an active arterial hemorrhage, and usually that's the time I get the call, and we are usually ready and waiting to proceed with an angioembolization if the patient is stable enough to come to us. So of course, there's we always look at the guidelines, and there's guidelines. This is from the Society of Intervention Radiology, and these guidelines is published in 2020 to explain the standard of practice and the position of intervention radiology in trauma. So in the SIR guidelines, the indications for angiography and possible embolization includes a pelvic ring fracture visualized on plain radiograph in a patient who is hemodynamically unstable condition in whom an intrathoracic or intra-abdominal source of bleed has been excluded. So any form of imaging, all right? And of course, secondly is any vascular injury or contrast agent extravasation that you see on the CT scan, all right? And you can see multiple different types of findings when you're looking at pelvic trauma. You can see active contrast extravasation, or they can look in different manners. You know, some can have a pseudoaneurysm, there can be vasospasm or arterial stretch injury, or a vascular cutoff sign. So you can see these different types of appearances. But currently on the SIR guideline, there's no consensus for you to move directly to angio, and there's no superiority of CT imaging. So CT imaging is still the first line when we want to image a patient in trauma before going to the angio suite. So we don't push to the angio suite straight away. So this is just part of the guidelines that were demonstrated in the SIR guidelines, but I will show you a more comprehensible trauma algorithm that I can think of. And this is quite simplified. I think the trauma team is more knowledgeable in this field, and they are well prepared in handling any patient with trauma. But just to show you that angiography is down here, and this is where we come in to any form of in any form of injury. So the hybrid setup. So this is a setup that I think is ideal, and this is a hybrid angio OT. So you can see quite clearly there's a C-arm, there's an CT scanner, you know, the patient after trauma. After the CT scanner, there's always the ability of a C-arm here. There's a GA machine. The patient can be opened because this is catered to be like an OT. And this is like an ideal system that I think if we should strive for, because we are a country with a lot of trauma, and investing in such a system is actually pretty good. But the DCR in Hospital Sungai Buloh is already extensive, and Shah has done a great work in putting that up. And we are still in the discussions of trying to figure out how we're going to move after this COVID era to help deal with trauma even better. So this is another example. So the problem about this place is, I think space is an issue. And I think the operating surgeon will probably not be very happy with such a crowded room. And this would be even better. All right. Granted, it doesn't have a CT scan, but you've got an angio that can actually come in to the table, and you can do your procedure over here and bring it out, and someone can operate on the patient on this table. So this is where I think in a hybrid setup, space has to be good and big if you're going to do any form of surgery. So if we look at studies and trials, so this one was published in 2021. All right, having a dedicated trauma hybrid operating room. And they realized that they have early hemorrhagic control if they use a REBOA. So I'll kind of explain what a REBOA is. All right. They have fewer early transfusions, fewer ventilator days, and fewer infectious complications. This is by having a dedicated trauma operating room. That means the patient is resuscitated and operated on the same room, like what I showed just now. All right. So when it comes to patient comes to me, the most important thing, of course, is I have to be very well versed with the angiographic anatomy of the pelvis. And this is generally what's the kind of image that I will end up seeing. And so when I start, I usually, the angio room is kept empty. They usually inform me that there's a patient for for a pelvic embolization and an acute trauma patient that's coming down. So we usually wait and keep the room empty with our staff all on standby. So when the patient arrives, you are straight away ready to go. So we put in a short sheet, as you can see, a sheet inserted over here, and we do an angiogram, and we have to understand the anatomy first before we are able to proceed with any form of embolization. So if you look at the anatomy, yes, you've got the external iliac and you have the internal iliac. All right. So there's the external iliac and the internal iliac over here. All right. And that's the common iliac up there. All right. So the puncture is usually at the common femoral or the superficial femoral. So you can see the femoral head over here. All right. So that's the angiogram that we do, and you can see. I'm going to show you the detailed anatomy. So this is actually showing the posterior division of the internal iliac. So this is your iliolumbar artery, as you can see, going up here. The superior gluteal artery is the largest branch that goes to the buttock, and you've got the lateral sacral artery coming here. So this is what it looks like on the angiogram, and this is what we generally see. All right. And then we go to the more complex anterior division, and this is usually where most of the culprit of pelvic bleeders are. And as you can see, you've got the inferior gluteal artery, which is the largest branch that you can see over here. All right, that's the inferior gluteal artery. Then you've got the inferior vesicle to bladder or pelvic organs, the inferior vesical artery. All right, then you've got the obturator artery, which goes to the obturator canal, and you've got the internal pudendal artery. All right. So this is the complex anatomy that I'm looking at when I'm assessing the patient. And then of course I have to look at the external, the external iliac, and you've got the circumflex iliac artery, you've got the inferior epigastric artery, you've got the superficial iliac circumflex artery, external pudendal artery, and then you've got the femoral artery coming up here. So this is a common view of what we see. Okay, so this is a crossover view when we put the catheter coming from one end, usually from the left, and we cross into the right, and we shoot an angiogram looking for the source of bleed. So these are the complex anatomy in the pelvis and the arteries involved, and we always assess carefully before we say that we are done. And when we look at angiographic findings in injury, so you can have multiple types of findings. You can either have an arterial cutoff, you can have vessel irregularity, you can have a dissection, you can have thrombosis, you can have stagnant pooling, vasoconstriction, pseudoaneurysms, AV fistula, vessel displacement, or intraparenchymal avascular zones. So those are types of diffuse angiographic findings that you tend to see. So as I explained, the technique is either from bilateral, femoral, or radial, but most of the time it's patients, it's easier for us to access from femoral because from radial, you're most of the time the patient either has a lot of lines or may have a fracture of the upper limb, or may have an associated vascular injury somewhere in the thorax, and that may be a problem for you. And then you do internal iliac angiography, either using a Cobra or a SIM catheter. And the best view for you to get is a contralateral oblique view. So you either do an oblique view for you to lay out the anterior and posterior divisions well, and you do an ipsilateral oblique view to have good visualization of the superior gluteal artery. And you have to consider always complete by doing an external iliac angiography, just in case you've got a corona mortis. I'll explain and I'll show you an example of that in a real case, and looking bleeders in the inferior epigastric artery and deep circumflex iliac artery. So embolization, when we do embolization, it's always selective embolization whenever possible. All right. So we use either coils to injury for any injured arteries, or AV fistula or pseudoaneurysms, and gel foam for most other injuries. So gel foam is a very is a temporary embolic material, and I think a lot of surgeons are well versed with gel foam, and we use it intravascularly. But sometimes embolization does fail. We are not always successful. Sometimes it fails in 10% of patients. Sometimes it's usually due to missed arterial bleeding due to temporary vasospasm, and this is quite common. We go in, we can't really find a place of bleed because of vasospasm, or it's a venous bleed, and usually we can't access venous bleeds. All right. So there is also this argument that we should do non-selective gel foam slurry embolization of bilateral internal iliac artery. So this is usually done in patients who are hemodynamically unstable, continues to bleed despite apparent successful embolization or multiple bleeding sites bilaterally. So usually when the patient comes down, the patient is usually accompanied by the anesthesiologist, usually the EP is there, the EP registrar, emergency registrar is there, sometimes the general surgery team is there. And you will see the hemodynamics immediately start to change once you do an embolization, and you see the patient start stabilizing, you know. Of course, warranted, there's a lot of ongoing, you know, blood transfusion and fluid management that's going on. But I think that once you do the embolization, you'll really see the difference in the hemodynamics of the patient. And you see, and you know that you have secured your bleeder. So there is, of course, this divided opinion of non-selective embolization, whereby you give gel foam particles bilaterally. All right. So it has been shown in multiple papers to be safe. It shows a clinical control of bleeding in about 90% of patients. No severe in-hospital morbidity associated with embolization, and no evidence of pelvic or soft tissue ischemia on CT or autopsy. So doing a bilateral internal iliac gel foam particle embolization in the setting of an acute trauma as a life-saving maneuver is acceptable and pretty safe. All right. Complications are uncommon and are usually related to the injury, and they have found no long-term effects on urogenital function. It's of course a slight increase in risk of buttock and thigh paresthesia, and occasion skin sloughing and necrosis. So these are common complications that can happen. And as an intervention radiologist, you should also inform all the primary teams, and all the team players should be aware of this kind of complications that can happen. And we should always, as intervention radiologists, we are told to recognize excessive embolization and not push too much. Once we see the flow has slightly slowed down and there's reduction in inflow, we usually tend to stop. So I'm just going to walk you through some cases that we've done in Sungai Buloh and cases of acute trauma. So this is one of the patients that you can see. All right. So this patient presented to Hospital Sungai Buloh. You know, he's a trauma patient, and you can see a fracture in the femur, and you see this pelvic fracture over here, and you see evidence of the arrow pointing to evidence of active contrast extravasation. All right. So we go in and we start doing the angiogram, and you can see on the angiogram, as we shoot the angiogram, we can see a part of the operator artery. All right. And there's a contrast blush over here in the angiography. All right. So that's me doing the angiography, and you can see the contrast blush quite clearly over here, maybe a little bit over here. All right. Then you go for selective angiography, and that's where you pick up the bleeder, right? So you can see the bleeder quite clearly over there. So options here can be multiple. You can either use a coil, you can use some gel foam, you can use particle or any glue, and that's up to you. So after embolization, you can see in this patient, so this is a typical appearance of vasospasm that tends to happen, and it tends to happen especially in trauma when you put a catheter into a vessel. And so once you embolized, there's some glue there, and there's complete slowing down of flow. All right. And it's completely occluded, and you've arrested the bleed. And usually after this point, you know, the hemodynamics tend to stabilize. The patient starts getting better, and you know, you've done a good job, and this patient actually survived. All right. So for the second case of me showing you other examples of what we've had to deal with. So there's another patient in Hospital Sungai Buloh. So you can see a comminuted acetabular fracture over here. All right. And a pelvic fracture over here. And you see evidence of contrast extravasation over here. All right. So you must remember that our radiology team is always very pro trauma, and in the DCR, you know, when the DCR has a case of trauma or anyone calls us up for trauma, we always decide to do a pan CT. That's automatic for us. There's no arguments there. And I think every radiologist dealing with trauma should practice this. Okay. And so when we do the angiography, so you can see that this is a internal iliac artery angiogram. All right. So we see this is a different appearance. It doesn't show an acute contrast extravasation, but you see vessel irregularity and some just disbursement of contrast here. I don't think it is a genital stain, because if a genital stain, it should be somewhere here. As you can see, the penis is actually here, and the penis stops here. All right. So you can see that this is happening over here. So this is my angiogram. My catheter is there, and we do a more selective run, and we see contrast blush over here. And we put in a coil. This is a 1 centimeter coil, 2 by 1 centimeter coil. And after we coil it, and we've managed to arrest the bleeding. All right. And that's where you're done. So this is a different type of appearance of how an embolization or a bleed looks like. If you look at the third case, so I'm going to share another third case. So this is the third case showing a pelvic fracture, and this is actually showing a iliac fracture, and you can see the iliac wing is fractured over here on the left hand side, and you see evidence of this faint contrast over here. All right, as you go down, you see it coming down, and there's an iliac wing fracture, right? If we look at the delayed imaging, and then you start seeing more contrast pooling going on over here, all right, from the iliac wing. Patient was clinically unstable, brought down to the angio suite. So we decided to go in and shoot an angiogram. So we start seeing, you know, this contrast pooling areas all over, all right, even over here. And usually in such case, with such diffuse bleeds, we decide to give gel foam embolization as our way of hemodynamic control and control of bleeding. And the patient did very well. And so far, all the cases that we've had to deal with, we've never had a bad outcome so far. So there was no evidence of any gluteal necrosis or evidence of any paresthesia after giving the gel foam. All right. So just taking you the final case, just showing you an example of what a PAN-CT protocol looks like. So this is me, you know, highlighting once again the PAN-CT for trauma, right? And we do it from the top to the bottom. And I'll show you how important this is for this patient. So you see the complex pelvic fracture going on here, all right? And the injury that happens here. So this is what Faisal was talking about, that you've got good VRT images for you to visualize and be able to rotate and play around with the images, all right? So you can see that it's got a vertical fracture also here, all right? And so this is just to clearly highlight this patient. You know, he was 16 years old, a very young patient. He came in hemodynamically unstable. So this is one of those very clear signs that he's really unstable, because you see the IVC is completely flat. All right. It's not supposed to look like that. It's supposed to be nice and round. So he's clearly under volume at this point of time. You know, he's still losing blood. And then we did the CT scan. We see this active contrast extravasation on this side. Something going on over here. Also some contrast extravasation on this side. All right. And then as Faisal clearly and Muazzam clearly pointed out, that you've got associated polytrauma, and associated injuries. So this guy's got this injury up here with this. So we were not too sure whether this is a liver injury, but kind of looked like it. So at this point of time, I remember this was one day before, I think one day before GE14. And we spent almost the whole night performing an embolization on this guy. So this is just to show you an external iliac angiogram and showing you something called a corona mortis. So that's where there's a continuation from the inferior epigastric artery. It actually communicates with the internal iliac branch of the internal iliac, and the bleeding actually comes from there. You can see a very clear bleeder coming out from here, you know, contrast stain over here. You can see that. All right. So sometimes you also have some pitfalls when you do angiography. So this kind of looks like something going on here, but this is not. This is actually just your ureter and contrast flowing the ureter. So you don't have to worry about that. And this is something that you have to pick up. That's why we always ask you to check the external iliac artery to make sure that you're not missing such a situation. So when we went, so this is what a corona mortis looks like. You go in and you embolize it. All right. And we decided to embolize that patient. All right. This is of course in a different patient. And this is what the corona mortis looks like. All right. So it's a communication of the external iliac that kind of comes in through the inferior epigastric artery, and there's a communication into the obturator artery. All right. So we decided to put some coils there, and that problem was solved. All right. You can see over here, that problem was solved. There was no flow anymore. But then we started to see, if you can see all this faint, you know, this is all contrast media that's still there. So we decided to go and check, and we checked the branch of the internal pudendal artery, and there was bleeding coming from there with all this contrast extravasation. Right. So this is one of those, you know, situations where you go, oh, you know, you have to address it quite fast. And that's all the contrast pooling down there. All right. So once we had placed glue on this side, so after doing a glue embolization, so we managed to stop the bleeding in this region, and then we had to puncture the other side and cross over to the contralateral side, and we started seeing all these bleeders everywhere else. So we decided to give some glue, combination of glue, putting in some coils, and that's how we stopped the bleeding. And this boy actually did very well. All right. So after we finished that, then we had to go to the abdomen because we had to assess what's going on in the abdomen. So then we did a hepatic angiogram, and you can see that there's a clear bleeder happening in segment 6 over here. All right. So at this point of time, I had a junior doctor, and unfortunately, one of the coils had displaced, and usually it's not a problem because it's a very small segmental coil. But we decided to give some glue, and glue embolization happened, and we managed to close that single branch, and that's what the final angiogram looked like. All right. So as I mentioned, there's some pitfalls during angiography. You have ureteric peristalsis. We saw that earlier, right? Which can be a pitfall. It can look like there's something going on here, but that's actually for you to pick up as a person who's doing the procedure. All right. And you can have normal stain at the base of the penis sometimes, which you can think is an abnormality. And I showed you a case where we thought it wasn't. All right. And it didn't look like this at the base of the penis. That was somewhere lower down or in this region. All right. And you can have bowel gas misregistration. Yes, that also can happen during the angiography. All right. You think you see a kind of a bleeder, but then you have to pay close attention to it, and it's bowel gas misregistration. Okay. So coming towards the end of my talk, so we talk about the complications of embolization. Yes, there have been multiple reports of complications of embolization, but these are earlier studies, all right, using more primitive embolic material, and these are newer studies. So you can see in the newer studies, right, you have almost none or very minimal embolization complications, because most common, of course, is bilateral gluteal muscle necrosis. Those intervention radiologists who do treatment for internal iliac embolization for uterine artery, you know that you have experienced this. All right, you sometimes have thigh and buttock claudication, and some impotence. So these are pretty common complications that happen, and you have to be aware of. And I think, of course, we try to avoid them as much as possible. So we use large particles so that we don't go in and we just reduce the inflow as opposed to completely occluding the artery. And we hope that helps. So final few slides. So there's something also called as the ER REBOA. All right. So the REBOA is rapid expandable balloon of aorta. All right. So this is actually deployed in the ED itself, and in trained hands, it can be done. And you put it into a, so this is good because you put it into a 7 French system, as opposed to previous balloons in the olden days. A coda balloon needs a 14 French system, so you need a vascular incision to close the coda balloon. But REBOA, I think it's a 7 French. Intervention radiology should be able to solve the problem. And you usually put it in separate locations. All right. And for pelvic fractures, you tend to put it in zone 3, but you really need to be careful, because once you have to know where you are. That's where having the hybrid system tends to work very well. And once you inflate the balloon, the clock ticks, and you have to have definitive treatment thereafter, either going for surgery or going for embolization. So this is something to think about. I don't think it's available in Malaysia right now, but you never know. It may happen in the future. Okay, so you can use it for any thoracic injury also, any acute thoracic injury. But I think you have to be very careful and trained to be able to use this. So in conclusion, I think pelvic embolization in trauma centers plays a crucial part of the management of pelvic trauma. I do know that we are at step 7, as Mozam had pointed out, but I think with centers with intervention radiologists, you should remember that trauma is crucial. It can happen to anyone, so you have to always be ready for such patients to come, and we always are in our team, Dr. Zol and I. And a hybrid setting has got multiple advantages, and almost 20% of all hybrid cases include angiography. A PAN-CT definitely identifies bleeders to be tackled and picks up situations outside the pelvis. So as I showed you one of the cases quite clearly, you can see the bleeders in the liver. All right. There's a significant difference in mortality if embolization performed after 60 minutes presentation to the ED. So this is actually one of the papers, from Japan, and they came up with this conclusion. They said that there's a clear increased risk of mortality from doing an embolization after 60 minutes. So we try our level best. If we can resuscitate the patient fast enough and get them down to the angio suite, definitely outcomes are better. So we once again also mix a hybrid angio suite with a DCR and also an OT, something that's very feasible, and it helps reduce time. So pelvic embolization is fast, effective, and efficient with experience. And blend large particle gel form embolization has minimal risk of complications. So, when you need to do life-saving procedures, I think, and you cannot super selectively embolize a situation, I think this is still an option. All right. And you must know that ER REBOA and its role and its immediate definitive treatment. So I hope I've shined some light on pelvic embolization. So I thank you very much. So this is our team. Results not here anymore, but it's Dr. Zul and me. So we handle the angio suite in Hospital Sungai Buloh. Thank you.
Okay, thank you very much, Dr. Arvin, for the wonderful presentation. And I think it's a very interesting to find another advocate of Pen City for trauma. Like previously we had to fight for Pen City, and now we have many advocates for that, and we are very thankful for that. And thank you for giving us a peek into the angio suite and see how patients are, because often we send the patients straight from ED and then we never knew what happened to the patient. So it's like as emergency physicians or those who are working in ED, we often look at the patients and we see and we try to decipher and manage our best. And it's always the surgeons who manage to take a peek into the patient and when they cut the patients and open. And it's always the radiologist who is able to look at the patient from every angle and every aspect that they want. So, and it's very good that we have all three here, and we would like to proceed to the Q&A. So I'd like to invite Dr. Faisal to on your video. All right. So due to the time constraint, I'll just have one or two questions for all the presenters. So we'll start with Dr. Azan first. There's a question on pelvic binder. Is it appropriate to put it on patients with a vertical shear pelvic fracture and also patients that possibly has a dislocated pelvic? So do you still put the pelvic binder on?
All right. Thank you, Natalie, for that question. The answer would be yes to both, right? Because actually, a vertical shear is one of the mechanisms of injury that you really need to put on the pelvic binder, because it has one of the highest risks of bleeding. All right, and for the dislocation part, I think as a clinician, you need to go risk versus benefit, okay, for all your patients. So in this situation, if you have a unstable pelvic fracture with a dislocated femur, then the issue will be, if you don't bind the pelvis, then the patient will can go to shock, refractory shock, so patient will be unstable, versus the issue of the dislocation of the issues that you arise only with just the dislocation. So I think it's also life versus limb. So in both situations, we advocate to put on the pelvic binder, and hopefully with this, you get to get a tamponade effect, you get to stop the bleeding, you get to give temporary stability for the pelvis.
Okay, thank you, Dr. Azan. And we have another question in the chat box for Dr. Faisal. It says here that if, and commonly we get, where the patient has a concurrent unstable pelvic fracture and also a big unstable intra-abdominal bleed, and when the patient goes into the OT, which will you do first? Oftentimes we will hear that the surgical team and the orthopedic team will go in together. So we would like to know what happens in the OT actually.
Okay, thank you, Dr. Natalie. Thank you, Dr. Sabaria, for the very good question. So what happened and what we advocate, because we do know that the pelvic cavity, especially with the open book, you keep on, like, you can have pooling of blood inside there. So ideally, logically, even though some might argue that, okay, we go for abdomen first and after that, then you stabilize the pelvic, but most generally consensus take it as you stabilize the pelvic ring first, so that you have to a certain extent the tamponade effect. And then when you want to manipulate, you want to do surgery, so the pelvic doesn't move too much, because when the pelvic keep on moving, let's say you cut the abdomen open, you manipulate this, manipulate that, the bleed tend to bleed further, like the fresh clot that try to form a proper clot, they become dislodged. especially if the BP is not well controlled, if patient in pain and all. So there's always an issue with that. So ideally, to answer it, the best thing to do is to stabilize the pelvic first. And then I do understand that the configuration of the bar on top of the abdomen sometimes can actually obscure. I can prevent the exposure. So we have a way to angle the bar inferiorly so that the abdomen can be free. So it is one of the modality that we can do. Yeah, so that's number one. And the second question I see,
Yes,
if you
Grab driver.
yes, with regards to the Grab driver, let me try to share back the slides here. Okay, so with this Grab driver, what he has is, if you can see, the right side is okay, the pubic rami, okay, it doesn't seem to be open up here. And if you were to follow it, you can see the iliac crest, there's a fracture there. And there seems to be like certain degree if it open up of the SI joint here, most likely anterior and posterior sacroiliac ligaments already been torn up. Unfortunate for the patient, I do not know how long patient was sitting there. Maybe like he looked clinically stable. I do understand there's a limitation in our era of COVID, the number of patients that we do have and we do receive to our emergency department. So this patient could be sitting there for a while, then patient suddenly collapse because there's with the element of the little trial of death. When there's element of coagulopathy, acidosis, and hypothermia, there's always possibility that the patient have all these three by the time that they pick it up. That's why he's not really responding so well to even 11 pint of packed cell transfusion, and etc. So if we were to look it back at this patient as a whole again, if we were to have the chance or the golden hours of opportunity to catch him where it's really matter, so if you were to send to either yellow zone or to resus, ideally resus with this kind of patient, so we put a binder because if you were to put a binder, it seems to be closing up quite well here, so it can affect a tamponade effect. Then subsequently, if patient, even with the blood transfusion, with the inotropic support, and patient still BP doesn't pick up, then we can go to OT and stabilize further. But if you were to ask my personal opinion, I think we missed the opportunity window of the hour opportunity. So he is unfortunately that because of that. So maybe it can be further improved on that in the future. With regards to the question that Dr. Muhazzan answered just now with the vertical shear, I agree with him and Dr. Shah as well, where about there's always thing called life before limb. Yes, you have dislocation of the hip. What could be the worst thing that happened if you have dislocation hip? Number one, sciatic nerve injury, then you get foot drop. Okay, fair enough, but life is always more than important than that. Another thing, if let's say it's dislocation really bad and then your vessels, the femoral artery got kinked, then you might have a gangrenous or become maybe like there's intimal damage to the vessels there. So the leg might go into gangrene. But again, life before limb. If you suspect patient who are unstable, you think there's a pelvic fracture, you stabilize the pelvic ring. Especially in a vertical shear, when it goes up, if you have the opportunity to track it down using skeletal pin and then put a binder, by all means do that. But if you can't, the least you can do is just put the binder on. And after that, we can assess, we can stabilize the patient further. Usually the binder, we don't put forever. Usually we put for like 24 hours. Then after that, once the hemodynamic is stable, we can reassess back again by opening up. And if a patient feasible to go to OT, external fixator can be a temporary device before the definitive management by putting a plate. With regards to the Grab driver just now as well, let me try to share another thing that where is it just now? Sorry, I tried to do it again. Okay, so this is Dr. Arvind here, the good-looking guy here, looking down. So I screenshot his presentation just now. For the Grab driver, what he has is almost similar as this, but he has iliac fracture. This on the contralateral on the left side. So he has the iliac fracture here. In this picture, there's a sacrum fracture here, the sacral fracture, but that case most likely is open up rather than through and through. This is you can see the fragment here, fracture here, fracture here, fracture here. The whole thing becomes vertical shear. You might look on the left side here, looks okay, but if you were to compare, because people I do have this tendency when I was younger. I thought like, okay, vertical shear usually as I join the movement and then the whole thing goes up, but not really. You can see this very good example where the fracture through the sacrum itself, and then you can see the ramus fracture. So the whole thing shifted up as well. Huh? All right. In our Grab driver, he doesn't have a femur fracture, and they already rule out intrathoracic, intra-abdomen, and other source of bleeding from other long bones. So it's actually just purely pelvic itself. So if you were to close back again and then stabilize further, there's a good chance that he might survive. Okay, I think that's the point that I can point out from this one. Any other question I can help you with?
Yeah, I think that's the only question we have for you. And we do agree that time is really life, and every single minute that it's spent is actually every minute that their life taking away if we are not managing them well. So we have a question for Dr. Arvind as well, and there's a question that asks. I think it's better for you to answer. So there's a question that in unstable isolated pelvic injury, do I order contrasted CT pelvis or only with CTA? So my understanding is this person is asking if we don't need a pen CT for the patient. So maybe you can give us an answer for that.
Okay, so sure. If the patient has an unstable pelvic injury, I'm quite sure the patient is also clinically and hemodynamically unstable. So you definitely have to rule out an injury elsewhere, because you don't want to be sitting on an injury, that's going on elsewhere and no one is picking it up. Personally, and this is once again, what I think we kind of practice in our trauma center, as it's a DCR protocol, we go for a pen CT, and we do something called a split bolus. So there's no such thing as a CTA or a CTV. It is a split bolus that is somewhere in between. So it shows very good arterial enhancement and also shows very good venous enhancement. It can sometimes be a bit difficult for the intervention radiologist to pick out where exactly the bleed is, and maybe probably in 5 to 10% of the time you go in and you do an angiogram, you won't be able to pick up the bleeding, and then finally you come to the conclusion that it's venous. But I think it was you, me, or anyone else who's had a trauma, and I would go all out for you the same way I would expect someone to go all out for me, And I have no problems going and doing an angiogram and finally seeing nothing there, and we all are very happy. Everyone can breathe a bit more easier, yes. Right? It's after all a CT scan, So that's my opinion.
Yep, and I totally agree with you. And I think most of our trauma centers, we actually have this template where it's actually like a checkbox. So it's a template that's agreed between ED and radiologists, like these are the injuries, these are how the patient presented, and this patient is eligible for a pen CT. So I think it's really good to come talk to your hospital radiologist and come out with a protocol so that you don't miss any patients.
So just to highlight another thing, at this point of time, we shouldn't be asking the renal profile, what's the
yes.
the patient's last meal. And I think all that should be out the window at this point of time, because there's no point waiting for all this. You have to save the patient's life.
Yep. Yeah. And from our experience here in Sungai Buloh, sometimes when we ourselves are unsure or if patient does fulfill, but there's something that we need to highlight, we always call the radiologist as well, and just to tell them like, this patient, I think is this, can you just tell me on that? And we make it a practice that the attending physicians actually follow the patient to the CT suite so that we can catch the injury straight. And while the patient is, being transferred and they are finalizing the CT, we already pick up the phone, and some of the surgeons are there together with us, with orthopedic surgeon as well, if they think that is part of their injury. So it's something really good that you should have in hospital level.
As you can see, in Faisal's case, the Grab driver, he's probably alert and well, and then everyone's waiting for saying, oh, he doesn't need the CT right now, we can wait for his renal function and this and that and all. I think maybe we need to rethink about that, in a session of polytrauma or acute trauma with quite high impact injury.
Yeah, we agree. If one pen CT can save 11 PEC cells. And one more question for Dr. Arvind. How often do you do angioembolization for pelvic fracture in hospital setting, and how is the outcome of your patients?
Okay, so far I think we've taken data from 2018. So you must remember that we are now a COVID hospital for the past 1 year, so almost 2 years. So our data is not so good. But from data from 2018 to 2020, beginning of 2020, I think February 2020, we have about 6 cases of pelvic embolizations. All right, and I've shown you 4 of them.
Yeah.
All right. So that's about how often that they are able to come down. Maybe because they don't reach me, or they probably don't make it, is one more option, or they've gone to the OT. I mean, it kind of happens, you know. Sometimes
Yeah.
they are just unstable, not stable enough to come down, you know. And that's why I think, you know, when I highlighted the hybrid room, which, you know, you can bring me up there, would be much better. And I come to the area and I help you guys out in that process, you know.
Yep. I think that's awesome. Let's go forward for the hybrid. Okay. Thank you everyone for joining us and staying on with us. So due to time constraint, there are a few more other questions which we will answer in the chat box, and some of the answers will be posted up later on as well. So thank you to Medic Shifa again for sponsoring us and making this happen. And for all of you, the e-cert will be posted up after this, and feel free to snapshot and fill it out. Okay, thank you very much. Thank you, Dr. Azan, Dr. Faisal, and Dr. Arvin for your kind sharing and helping and educating all our frontliners here. Thank you. See you guys again next month.
Thank you so much. Take care, everybody.
Thank you, guys.
Thank you. Stay safe. Thank you very much.
All right.